I welcome everybody, and I thank our esteemed speakers, very good colleagues, very esteemed speakers, and it's very, very nice that we joined. Dr. Assam Al-Touqi from Egypt will be moderating the session with me. He is a professor and head of the Oculoplastic Service, Cairo University. There will be 4 speakers: Dr. Francisco Corantellioni from Rome, and he will speak about the canalicular lacrimal obstructions and management. Dr. Francisco Corantellioni, as I know him, he is the president of the Soberos. He's director of Adnexal and Orbital Service in Rome, Terbe Hospital, and GVM Care Research Rome, medical director of Ophthalmoplastica Rome, adjunct professor, Faculty of Medicine Surgery, University of Pavia. I welcome Dr. Francisco Corantellioni, and the floor is yours, and I'm sure that we are going to hear very nice.
Thank you very much. Thank you very much to all of you for inviting me. And I'm trying to share my video, so it should be okay. But I mean, when I try to share my screen, they say it's not possible.
So now you can share your screen.
No, they say
you can try again. Just share and wait a little bit. It will come. We see you clearly.
Okay.
Yes, yes. Management of canalicular obstruction. We see it clearly. Yes.
Okay, thank you very much. So just let me know if just slides go. Okay, I've been asked to talk about the management of canalicular obstructions, and I have no financial interest to disclose. And so when we are talking about this topic, the main thing to think about is that when we deal with these patients, most of these patients have just a symptom, which is a watery eye and not a disease. So the big question we should ask is always necessary to perform a lesser Jones tube in case of canalicular obstruction? Because I mean, sometimes we do it, sometimes we don't. So is there a rationale behind it? And we were very curious about it. So at first last year, we published a paper about our experience to try to define a rationale behind proximal lacrimal obstruction, so how to manage them. And then we were even more curious, so we reviewed most of the literature about this topic to just clarify the level of evidence of several procedures to see what other people did with it. And what did we find out? That the first important thing is an accurate identification of the site of the obstruction is essential. And second, the patient history. And third, that less invasive techniques are obviously to be reserved to patients with no associated nasolacrimal duct obstruction. All these 3 things seem to be very obvious, but I can assure you that they are not, because sometimes if you read the literature about this topic, then you will see that very interesting procedures are suggested not for the right type of canalicular obstruction. This is why sometimes the findings are not that good. Anyway, the first thing is to classify the canalicular obstruction. So we have to clearly distinguish when we have our patients between proximal obstructions, so within 4 millimeters, mid-canalicular obstructions, patency between 4 and 8 millimeters, distal canalicular obstruction when we have at least 8 millimeters of patency from the lower punctum. The lower canaliculus is what interests most, as we all know. And of course, common canalicular obstruction when there is a membrane at the level of the common canaliculus. And what do we do usually? I mean, basically, for our patients, what we did is to distinguish patients if they had or not previous symptoms or history of associated nasolacrimal duct obstructions. So if we suspect then there is a canalicular obstructions, which is secondary to nasolacrimal duct obstructions. Then in case of proximal obstructions, we would go for a retrograde DCR. For mid-canalicular obstructions, a retrograde DCR is possible, but most of these patients will need the Lester-Jones tubes. For distal canalicular obstructions, then we go directly for Lester-Jones tube. And for common canalicular obstruction, we have to distinguish between medial and lateral common canalicular obstruction. So we can either choose a CDCR or a DCR and a membranectomy. We go through that quickly. The thing is different when we see patients that have a canalicular obstructions, which is secondary to chemotherapy or to glaucoma drops, anything else, or iatrogenic management of canaliculi. But I mean, these patients, we are pretty sure they did not have symptoms of previous nasolacrimal duct obstructions. So for proximal obstructions, we can do endoscopy. That's not absolutely necessary. You can do trephination and intubation. For mid-canalicular obstructions, we find that there is very useful the use of this self-retaining bicanalicular intubation set. For distal canalicular obstruction, I'll show you how Lacrijet is useful. And for common canalicular obstructions, you can use a bicanalicular intubation that you like. So what about proximal lacrimal obstructions? DCR and retrograde intubation is a standard operation. You do an external DCR, you identify the internal opening of the common canaliculus, and you just intubate starting from the inner part of the system. And this is very successful if there is a proximal lacrimal obstructions with a patency of at least 4 millimeters, and is absolutely not useful, at least in our hands, according to our experience, if you have to create a false passage through a not patent lower canaliculus. So if there is no, is not possible to identify the lower punctum, then I would go directly for a Lester-Jones tube. For mid-canalicular obstructions, when you are pretty sure that is just a mid-canalicular obstruction, so the patient had chemotherapy, or I mean, the patient is under treatment for a glaucoma with any kind of drugs, then this is very useful, very easy, and you can do trephination, membranectomy, and you can place this self-retaining intubation set that can be office set. You don't need operating theater for that. That's very easy and quite successful. For distal canalicular obstruction, what I find very, very convenient is the use of this preloaded self-retaining monocanalicular intubation, because you can do trephination and positioning of the intubation set of a monocanalicular stent with one single device. The important thing is that we have to have the integrity of the inferior punctum, and we have to tell the patient that we need to keep the stent for about 8 weeks. Finally, when we talk about proximal common canalicular obstruction and we have a distal obstruction, I still found useful, even in selected cases, to use a CDCR. CDCR is not a Lester-Jones tube, but is the canalicular dacryocystorenectomy that was proposed by J.G. Hurwitz, a Canadian colleague that sadly passed away very recently. And basically, it is an anastomosis between the end part of both canaliculi with the nasal mucosa. And so you have to excise very carefully the fibrous tissue at the end of the canaliculi. And during the operation, you have to distinguish this from the distal common canalicular obstructions. As you can see in this DCG, if you have the whole of the canaliculus, the common canaliculus patent, then this is not basically a canalicular obstruction is just a distal common canalicular obstruction, so DCR and membranectomy will be okay. So is there still a reason to do a bypass surgery? Basically, in my experience, is either redo surgery following a failed retrograde DCR or a CDCR, or if I see a complete canalicular obstruction. So in this case, as it is a reduced surgery, I would go for a closed Lesser-Jones tube placement. So you pave the way with a K-wire. As we all know, you need, of course, a nasal endoscopy to see what's happening. Then you enlarge the rod, and with this sizer, you can very easily establish the length of the width and the width of the tube that you need. You have several sizes, so you can go for either 3.54 or 4.5 millimeters with the length from 12, 12.5 to 14 or 15 millimeters. And then it's very helpful to have these stop-loss tubes with a flange, so the flange avoid migration of the tube most of the times, and it's very important to keep the flange well distanced from the lateral wall of the nose. And I think it's very important to fix it at the lateral canthus, and I usually keep this tiny bolster for up to 3 weeks to be sure that the tube is very well positioned. And of course, the success is when you have a Lesser-Jones tube well positioned, stable, and not visible. But do we have complications? Of course we do. There was a recent paper about double vision. I had a couple of patients recently who experienced diplopia following that. But there is one thing, air reflux. So we have to tell this patient that they will experience air reflux while they blow their nose. They are not used to that. And also one important thing, we have to tell the patient we are curing flush-related symptoms, not volume-related symptoms that these patients never experienced before, or most of them never did. And we have to tell the patients that after the operations, the watery eye may occasionally become a sticky eye. This happens when these patients get a flu or a cold, because there might be a reflux of mucus from the nasal cavity to the eye, which is not very nice for them. So they usually have a water eye, they don't like this. So we have to tell them. So basically, when we see patients with canalicular obstructions, patient history and accurate diagnosis of the site of the obstructions are essential for a correct surgical choice. Less invasive techniques are very useful, but have to be reserved to patients in which we are about to be sure that they don't have associated nasolacrimal ductal obstruction. And bypass surgery is, of course, the treatment of choice if there is no residual patency, but success may not match satisfaction and comfort. Rates of extrusion are reduced with the new types of tubes with the silicone flange. Thank you very much for your attention.
Well, thank you. Thank you, Dr. Francesco. That was very nice presentation, comprehensive. And I think there is a time for some questions or some, let us say, comments on this subject. Anybody of our panelists would like to?
Yes.
I have a question.
Yes.
Okay.
Okay.
Yes, Dr.
I
Susan.
have a quick comment.
Okay, Dr. Susan.
A quick question, Francesco. You talk about a membranectomy, and can you just explain, so I'm sure that I understand the difference between that and your trephination or other procedures?
Yes, the membranectomy, yes, basically is the same thing, but the trephination is, of course, when you do a closed procedure, for example, for a membrane, because you either know that developed after another medical surgical procedure, like a previous DCR, and that's, you do a trephination just because you have a secondary membrane. The membranectomy done at surgery is when you have what is supposed to be a common canalicular obstruction. Then at surgery, you find out that only you have a membrane at the end of the common canaliculus. So with your probe, or when you perform your intubation, you just break the membrane and you intubate, and you don't have to perform any other surgery than a standard DCRs and the membranectomy. I hope it's, I mean, I've been clear. Thanks.
Thank
Dr.
you.
Dr. Assam had something. He raised hand.
Yes, I agree with Francesco that at the end it's a choice between trephination with DCR versus Jones tube. But I also many times now have been using Botox injection in the lacrimal gland. And
Yes.
for a lot of patients, this is a good option, at least for the beginning before they decide on doing a procedure.
I agree with you. This is, I mean, this is absolutely good for some patients. It's like, I mean, when you do cosmetic surgery, some patients are very keen to have surgery, and some patients are very keen to have filler or Botox. There are two classes of patients. I think, as you mentioned, you have to deal with both, and you have to know how to manage to keep the patient satisfied. I agree with that. Some patients would, I mean, would go for surgery. Some patients would not. And for those, I think Botox is a good alternative.
Fine, fine. May I call Dr. Osama? Where is Dr. Osama? Dr. Osama is around. Dr. Osama Ababne. Fine. So, okay, since Dr. Osama is not around, Dr. Suzanne, could you start your talk, at least one of them? I know you have two talks. So could you start the abnormal presentation of TED presentation?
Sure.
Please, can you share your screen? Yes.
All right. Can you see that?
It. Yes, we
Okay.
can see that clearly. Thank you.
So these are my financial disclosures, and the Horizon Therapeutics relationship is pertinent to this presentation. So I have a 70-year-old white man who had pitting edema and festoons of both lower eyelids, right more than left, getting worse over 3 months. It started one day while he was on the golf course with his friends smoking a cigar, and the grass had been recently cut, and they were thinking that he was having an allergic reaction to the cut grass. He was treated at an outside hospital for acute conjunctivitis, was given a variety of drops with no improvement. And then a week later, he developed bilateral ankle swelling. He saw his primary care doctor and his cardiologist, who treated him with diuretics, and he had a slight improvement in the legs, but no change in the eyelids. He was then referred to many specialists, including an allergist and several ophthalmologists. When I met him, his vision was baseline at 20/40. There was no afferent pupillary defect. He had restricted motility slightly horizontally and in upgaze. His pressures were 18. His color vision was normal, and her TEL exophthalmometry was 28 and 27. And this is an external photograph at presentation. So common things being common, I was pretty suspicious for more than just allergy and eyelid. In my world, thyroid eye disease is very common, and he had proptosis and restricted motility in both eyes, and conjunctival injection and a little chemosis. And so I thought, this looks like thyroid eye disease. So I checked with his primary care doctor, and they said, oh yeah, no, it's not thyroid eye disease. His TSH, T3, and T4 were all normal. And I've never, seen a thyroid problem look like this. And I disagreed. So I got a CAT scan, and he had enlargement of his extraocular muscles with sparing of the tendons, and significant enlargement in both orbits of the muscles in a pattern consistent with thyroid eye disease with sparing of the lateral recti. His visual field on the left was definitely normal. On the right, he had some scattered inferior changes. And I did a little more extensive blood testing, And although his TSH and T4 were normal, his thyroglobulin antibody and thyroid peroxidase antibody levels were elevated. So this to me was further confirming my clinical suspicion for thyroid eye disease. So I needed to talk to his doctors about his management going forward, and they still denied that he had thyroid eye disease. So this was a very frustrating situation. It felt like me against the world, but I knew I was right in this case. So the question was management. You're very familiar, I'm sure, with the options. So we have to frame thyroid management now in time. So this was in 2018, 2019. And he is an insulin-dependent diabetic, so high-dose steroid is not ideal for him. And in my opinion, radiation therapy is relatively contraindicated in people with diabetes because of their pre-existing microvascular disease. He had a history of heavy alcohol use, and so we had some concern for his liver. So we wanted to be careful with IV steroid or high-dose other steroid. So I wanted to consider a steroid-sparing option from the beginning for this patient. So he received rituximab, and we did a standard 1 gram dosing with 2 doses given about 1 month apart. So standard loading. And he had a very underwhelming result. So here he is side by side before treatment. His Hertel measurements were 28. After 2 doses of rituximab, there's not much difference. His Hertel measurements had improved by about 1 millimeter. He felt about the same. He was still very socially embarrassed. He's a working man who has friends and activities and hated his appearance. So what steps are next? So we're not satisfied with the outcome of his rituximab. We still don't really want to give steroid. He did get a 3rd dose of rituximab just to see if that would help. It didn't make much difference. And time marches on, and now it's 2020. And so Tepratamumab has become available in the United States. It's the first and only US FDA-approved drug for thyroid eye disease. Previously, this was a cancer drug. It had failed, but was well tolerated and was repurposed for thyroid eye disease after the realization that IGF-1 receptor antagonists can be helpful. So this drug is FDA approved for moderate to severe thyroid eye disease and has very broad FDA indications. It's an infusion that's given every 3 weeks for 8 doses. The logistical issues are that it's very expensive medication, and so it sometimes requires a little battle with the insurance company. And also you have to arrange for either an infusion center or home infusion. The contraindications are inflammatory bowel disease, pregnancy and breastfeeding, and children less than 18 years of age because it affects the growth hormone and their growth. We use it with care in diabetics and in people with sensory neural hearing loss. So for this patient, his glucose levels definitely became elevated on the medication. But like most of my patients, he was able to manage it well with increasing doses of oral medications and insulin for the diabetes. So here he is after 3 of his 8 doses. I feel like he got a big result after the first 2 or 3. So his proptosis decreased from 28 and 27 down to 24. And you can see that his festoons have dried up. This is residual skin on the right lower lid, but I felt that the fluid had completely resolved. And here he is on the bottom right after completing all 8 doses. So I think the difference between dose 3 and dose 8 is a little bit of reduction of the fatty tissue in the eyelids and some further tightening of his skin. And this is a CT image of this patient before and after treatment. And you can see that the extraocular muscle enlargement has very significantly improved. In fact, almost approaching normal for many of the muscles. So that was a very big difference. So going forward, lower eyelid retraction surgery is planned for this patient. Tepratamumab is not great at fixing upper eyelid retraction. And in this patient, he still has negative vector, flat cheeks, prominent globes, and his lower lids have been weighed down mechanically by those bags of fluid for so long that lower lid surgery is going to be required. So we're stretching the indications of usage for tepratamumab as time goes by. The clinical trials did not include patients with compressive optic neuropathy or chronic thyroid eye disease. And my personal experience reflects the medical literature, which is now showing efficacy of tepratamumab in optic neuropathy, long-term chronic patients, and efficacy in patients who have failed traditional treatments. And I just came across this article by Erin Shriver and her group at the University of Iowa. And they were looking at patients who had had previous treatments who were chronic thyroid eye disease patients. And I apologize for how busy this slide is, but this area where it says prior treatments, you can see this group of 6 patients had had IV steroid, radiation, decompressions, tocilizumab, and you can see that they still had clinical activity scores ranging from 3 to 9. And after treatment, most of them had their activity scores decrease a lot, and their proptosis measurements also decreased. So showing us that this medicine sometimes is effective in patients who've had treatments with other medications that were thought to be good treatments for thyroid eye disease. So it's always an option, even where other things have failed. So thank you.
Thank you. Thank you, Dr. Suzanne Freitag. Dr. Suzanne Freitag, by the way, she is the director of ophthalmic plastic surgery from Massachusetts Eye and Ear Infirmary, Harvard Medical School. Very glad to have you with us. There is a place for comment or a question.
I have one question, Dr.
Yes,
Mahmoud.
Dr. Osama, please.
First, I'm sorry because I'm using a Wi-Fi connection, which sometimes disrupts and loses the connection. So sorry for this interruption. Do anybody know why the treatment, tepratamumab, is very expensive? I mean, it's really very, very expensive, and I don't know if it is available other than the USA. Why the cost of the regimen is like 400,000? Why is it so expensive?
It is because they can. It is being covered by insurance companies. It's only available in the United States currently, and the cost of drugs are very, very high. This is one of the higher ones, but our medical system works with this. I think it will be challenging to get this into other medical systems where this price tag is less possible, but these drugs are on patent for a certain number of years, and once they fall off patent, then the prices will radically change.
Fine. Actually, I am concerned about the abnormal representation of TED. It's very common to see that, especially if it is one eye unilateral cases, or if it is associated with myasthenia gravis or whatever, and you see ptosis in these patients instead of eyelid retraction. Dr. Francois Corantiglioni, could you comment on that abnormal representation of TED?
I mean, the case is just one of the cases we always see. So, I mean, I agree with Suzanne that sometimes we have to deal with people that say they don't have thyroid eye disease, instead they do. That's a common history, at least in Rome. So I'm not surprised about that. I mean, usually impressed as I usually am by tepratamumab. My question was about the same. If you think it will be possible in Europe, now we are in phase 3 for that, for the EMA, hopefully it will be approved this year, by this year in Europe as well. But the problem, of course, is the cost. But my question is another question. So have you, if you have experience now with tepratamumab, have you ever seen relapses, or after 1 year or 2 years, what happens? So patients that were successfully treated and then they have a relapse of their condition, what would you do?
So the safety of retreatment with a full course is thought to be okay. The OpticX data was just formally released in which patients received a second full course of Tepratamumab, and it was shown to be effective in about 65% of patients who had relapse, and in some people who had not responded at all. So my experience is I have 133 patients currently on drug or about to receive drug. I have retreated, or I'm actually just now retreating one patient. She did very well for 7 months. At that point, I did upper eyelid surgery on her. I did an internal recession of both upper lids and a blepharoplasty of both upper lids, and it set her off. And she got worse over 2 months. Her double vision came back. Her periorbital swelling came back. So she had a very rapid response to the first cycle of med. Her insurance company quickly approved her, and she's doing very, very well after 2 or 3 doses of her retreatment. I only have one other patient that we've seriously discussed retreating, and she was starting to get just a little bit of double vision back, but it wasn't progressing. And so we haven't retreated her yet. We're in a holding pattern for a number of months. So these are patients that finished their treatment about a year or a little over a year ago. My patients otherwise are doing okay so far. More time will tell. But one thing I've changed in my practice pattern is the timing of surgery. So now, rather than waiting to do eyelid surgery as we're generally taught to do, I'm actually moving toward doing the eyelid recession sooner to the time of completing their Tepratamumab. Hopefully there's still some drug effect, and that they won't occur later. So we'll see how that plays out.
Okay.
So sorry, Susan, I didn't catch the last part. So while you're treating, in the final phase of your treatment, then you perform upper eyelid surgery just to improve upper eyelid retraction, and then you complete the treatment with Tepratamumab. Is that correct?
I'm doing the surgery right after the Tepratamumab is completed, but sooner, within a few months, rather than waiting a year. Yep.
Okay, thanks.
Well, thank you, Dr. Susan. Fungal keratitis, the fungal orbital inflammation, whatever. Please.
So I wanted to talk about a case that I saw around the time that I was asked to participate in this meeting. And so this is someone that was fresh on my mind. None of my financial disclosures are pertinent to this presentation. So this is a 61-year-old white male with high-risk myelodysplastic syndrome who had been on a clinical trial drug and then recently was on daunorubicin and cytarabine for his MDS. He was admitted to the hospital for fatigue, headache, neutropenia, and fever, and shortly after developed right-sided facial pain. So this is his presentation for the general ophthalmology consultant that saw him. He was 20/30 in both eyes, no afferent pupillary defect. His motility had significant vertical restriction on the right. He was colorblind, so he had no color vision measurement. His intraocular pressure was 21 right, 12 left, 4 millimeters of right-sided proptosis, and some mild chemosis on the right side when the eye was opened. The most pertinent lab values were his white blood cell count was less than 1, his hemoglobin was 6, and his platelets were 51. So this is myelodysplastic syndrome on chemotherapy. And this is a selected image from his MRI showing sinus, right maxillary and ethmoid sinus, nasal opacification with some inferior and medial involvement of the right orbit with muscle enlargement and fat stranding. So we had a lot of concern in this highly immunocompromised patient about infection. We worried about bacterial infection. We also, of course, worried about fungal infection. One thing that was a little bit against fungal infection is that his vision was quite preserved on that side, but still we had a very low threshold for exploring. So our ear, nose, and throat colleagues performed endoscopy and biopsies. At this point, cultures were pending. No invasive fungal elements were reported on frozen section pathology. No black eschar was noted in the nose or the sinuses. And he was treated empirically with intravenous piperacillin, tazobactam, vancomycin, and amphotericin. So unfortunately, he developed double vision after surgery. And so my team was called for consultation. Now, this is the hospital across town. And so we're not immediately there, but we came later that day after we finished our clinic. And during that time, he developed acute mental status changes and additional imaging had been performed. So we were able to view these CT images. And so you can see the nose and sinuses have had recent surgery. And you can see the orbit looks similar. The muscles are enlarged in a similar pattern with stranding. Now, there is a dehiscence in the bone. I don't know if you can see my pointer, but on the far left slide, around the area where you would make a DCR incision in the lamina, there is a bone dehiscence. And so the ENT surgeon swore she did not make that opening, but it was there when she went in. And that is probably how this material is getting into the orbit. So on our exam, unfortunately, he has become uncooperative. He had no afferent pupillary defect. We could tell he still had severely restricted right eye motility. He still had proptosis, but he had a lot worse chemosis, inferior nasally on the right. And there was now a question of some right disc edema. So here he is recovering from his sinus surgery with continued erythema and edema of the right periocular area. So the question is, what do we do now? So he has these mental status issues. We were worried about the infectious process from his sinus and orbit getting into his brain. We were worried about a stroke. We were worried about delirium. Additional imaging showed no brain pathology, and a lumbar puncture was non-revealing, and his eye findings were getting a little bit worse. So ear, nose, and throat wanted to go back to the OR to further clean out the sinuses and biopsy, figuring if this is potentially fungus, mucor, that it would be good to clean things out further. They were pushing us very hard to go into the orbit from either externally or from the endoscopic approach to explore the orbit, to see if there's purulence, to drain things, to biopsy things. And we said no. We said the platelet count at this point was 50, maybe 48. And we decided the risk was too high of causing an orbital hemorrhage or other problems, given the sort of small involvement of orbital tissue. So ENT did their part, and we continued to monitor the orbit very closely. So then we learn that the ENT biopsies from this round are showing fungal elements, which are invasive in some areas. The lab reported numerous thin septate hyphae with variable branching. Differential diagnosis includes aspergillus or other hyaline molds. So now we're pretty convinced we're dealing with fungus. So we changed from the ambisome to voriconazole, mycofungin, and terbinafine. And the infectious disease doctors were recommending these changes and working very closely with us. After a few days, his mental status improved just enough to get a limited eye exam. His vision was decreased in the right, but there was no afferent defect. The pressures remained elevated, his motility remained limited, and he continued to have significant chemosis on the right. So his chemotherapy had been stopped when this all started. So his white blood cell count was now predictably starting to increase. It was only about 1.4, but it was showing a little progress each day. His platelet count was still very low. His mental status was still improving, but his orbits and sinuses were not improving clinically or radiographically. And you can see one of his repeat images on the right side. We deferred intraorbital antifungal injections, which we did talk about, again, because of the low platelet count. We didn't want to create more of a problem than he had. So the question is, what do we do next? We've stopped his immunosuppressive meds. His immune system is starting to come back. His brain is a little better. We still don't know what caused the brain problems. We think it may have been delirium. But then the lab called 14 days after the cultures were taken, and we received a diagnosis of Cetusporium apiospermum. And this was diagnosed based on selective culture media as well as DNA sequencing. And so this was very new to me because I have not knowingly dealt with a patient with Cetusporium before. And so we needed to figure out what to do. So infectious disease doctors were familiar with this, and they kept him on this cocktail of antifungals. And fortunately, 4 weeks later, he looked like this. And his motility had already improved to almost normal. His mental status was back to baseline, and he's looking much, much better. So we're very relieved at that point. I wanted to take just a moment to teach you a little bit about Cetusporium. It is a fungus that is an emerging opportunist. It usually has been associated with trauma in normal individuals, but it's now affecting immunosuppressed and debilitated people. It ranges in cystic fibrosis patients from just a colonization to local infections to severe disseminated disease. The mortality rates are extremely high, some reported as over 85% due to intrinsically sick patients, very difficult diagnostics for this fungus, and an intrinsic resistance to all antifungals. Now, interestingly, the Lomentaspora is very similar genus, and the Cetusporium is seen worldwide, but it's not so much reported in immunocompromised people as it is in these other pulmonary situations. However, on careful history, our patient owns a plant nursery, lives in a rural area, handles soil, and also handles animals like chickens and sheep very regularly.
Can you to sum it up? You have very few seconds to go, please.
So you can get corneal infections and endophthalmitis. It's difficult to distinguish from Aspergillus and Fusarium. And so nucleotide sequencing is the standard for diagnosis. And it's resistant to almost all antifungals. So voriconazole is the first line recommended therapy. And that's one of the most important points of my presentation is it's important to get these patients on voriconazole. Even so, the mortality is high. And unfortunately, my patient needs a bone marrow transplant. And he still has this living in his sinuses. So more will happen with this patient, I think, unfortunately. But this was a rare pathogen that we needed to learn a lot more about. And I just wanted to share it with others because I think we'll be seeing more of it.
Well, thank you so much. Thank you, Susan. Thank you, Francisco. Thanks to Dr. Touhi. Thanks for Farzad Bakdil and Dr. Osama Ababni. Thank you, everybody. That was very nice meeting. I hope you hear me. And we are just still in the air for say bye-bye. They are encroaching upon us. They cannot really give any time for a question or answer. Bye-bye, everybody. Thank you.
Thank you.
Bye-bye.
Thank you. Bye-bye. 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 Looking forward to see you again. Bye-bye. Bye-bye. Bye-bye.
Bye-bye. Thank you very much.
Bye-bye. Bye-bye.